so that she is able to discuss that. Can everyone see that okay?
Yes, we can. Thank you.
Right, Robin?
Okay, so my patient is a 32-year-old female. She was a truck driver, and around the age of 29, she met a man who introduced her to meth and heroin. So for a year, she used really heavy until she found out she was pregnant in June of 20. And then she started in the Suboxone program. She relapsed a couple times during the pregnancy, once in August and once in September. But she has been clean since September. She delivered preterm because of preeclampsia, but she has been clean. See, as of 6/3, that's when I had her in the office. She was clean 256 days. So she, I have a viral load from January and then again from June of this year. So she has a little bit of hypertension. You know, she got the preeclampsia during pregnancy, and it kind of carried over. So she's on lisinopril currently. Citalopram for depression, anxiety. She's having some iron replacement for a low saturation, vitamin D weekly, and then she's still enrolled in the Suboxone program. We've done her vaccinations, and she's got to get the second Hep A vaccination, but everything else is up to date now. So as far as her labs, her white blood cell count was normal. Her most everything on her labs looks really good. Her hemoglobin, hematocrit good. Platelets are within normal range. Creatinine is 0.71. Glucose was 68. Her INR 0.9, albumin 4.3. Her liver enzymes are well within normal range. Everything looks good. Her APRI was 0.303, and her child Turkitt Pew was class A. The MELD score was 6. So, you know, like I said before, her iron is a little bit low, so she is having replacement for that. Vitamin D replacing. I think the goal, you all wanted me to have that above 60, so that's going to be our goal there. So, you know, I think she's a good candidate. She's determined that she wants to stay clean. Seems like she's a very good mother. She's very attentive to her baby, and the baby comes with her to appointments. She has cut ties with her significant other because he's not quite ready to be clean. And so, you know, I think that she's on the right track to doing what she needs to do. But now the baby is negative for hepatitis C too. So I think she's a good candidate for treatment.
Thank you so much for that, Robin. It was an excellent presentation. And so just in your questions, you know, what treatment recommendations does everybody have, or any comments or concerns for Robin?
Hey, Robin, this is Kaylee. I just had a couple questions about is she on birth control right now? I know you said she's not really with a partner anymore, but any potential partners?
No, she's not on birth control, and we discussed that, and she's not planning to have a partner during the treatment process.
Okay. And I would just, you know, just reiterate that there's nothing approved in pregnancy with her if she does start, and that, you know, just to be upfront with you and maybe submit pregnancy screens if she doesn't wish to pursue. But it's probably not going to be harmful to the fetus, you know, if she became pregnant while on treatment. There's just not enough data to really support. There's not any studies with pregnancy, or I should say robust studies with pregnancy and Hep C treatment. So just something for her to be aware of. And, you know, even considering if she says she's not sexually active, to just do kind of monthly pregnancy screens on her anyway, just because she's childbearing age. And I'm sorry, I missed, did you speak about hepatitis B serology at all? Have you checked any Hep B serology on her, or do you know if she's vaccinated against Hep B?
I did check it, and she was negative. I'm pretty sure. Let me double check that, so I'm not going to be lying to you. I don't have it on this. She's negative. I know she's negative.
Okay.
Because Yeah, her Hep B was reactive, and so she's immune to that.
Okay, okay, perfect. All right. Yeah, I mean, with her treatment options, I'm going to go through, for those that kind of log on every week, it might be kind of reiterating the same thing. But if you're a new listener, I'm going to just go through the 4 treatment options that we kind of potentially have for a genotype 1A. So there's Hervoni. It can be 8 to 12 weeks. In her case, since her viral load is less than 6 million, she doesn't have cirrhosis, she's HIV negative. She could actually do an 8-week course. The other couple options, Epclusa, which is one of the pangenotypic agents, for 12 weeks, or Mavorite, the other pangenotypic agent, for 8 weeks, or Zepatir for 12 weeks, but since she's genotype 1A, you'd have to do that NS5A polymorphism testing at baseline. Now, any of those 4 treatment options would be fine. In her case, there's not any significant drug interactions. However, with Medicaid, the 2 preferred agents are generic Epclusa and Mavorite. So I would go with either of those. Like I said, with Mavorite, that's the one that interacts with some birth control methods. So anything containing ethinyl estradiol. And so, it doesn't sound like that's going to be something for her case. And that is a shorter duration, but it's 3 tablets that she has to take once daily with food. So if she doesn't eat consistently, that might not be the best choice for her. Epclusa would be the other option. It's a 12-week course, but it's 1 pill once a day and can be administered independent of food intake. And so either one of those, efficacy is the same. There's not really any difference. Otherwise, it comes down to kind of her preference.
Thank you so much, Kaylee. Appreciate that. Does anybody else have any questions or comments?
This is Jennifer Boyd. I think this is right, and tell me if I'm wrong, but I think to remember to have her kid tested again when he's 18 months. Is that right, Kim?
Yes, absolutely. So 18 months, I thought that it had said that maybe the baby was tested at birth and was negative, but honestly, not knowing what testing was done, if they did the RNA viral load or did an antibody screen, they should still do the antibody screen again at 18 months, since she could potentially have maternal antibodies until then. So yes, definitely, Jen. Good point. Thank you.
Thank you so much for that, Jen. Does anybody else have any recommendations or comments? Or Robin, did you have any other questions?
I don't think I have anything else.
Great. Thank you so much for that case. We really appreciate that. You did a wonderful job. I think Dr. Bailey said they had a call. I am just going to check if they're ready for me to do their case. Or we could, I don't know, Mitra, if they're not back, could we start with the didactic portion and come back to the case?
Yeah, absolutely. So I'm sure Dr. Bailey can chat in when she's ready for the case as well, but we could start part of the didactic and then go into the case when Dr. Bailey's back. It's just preference. Kaylee, what would you like to do if you'd like to speak? I would hate to cut you off, sort of a third of the way in or something. So
I do not care if you cut me off at all. so yeah, feel free to just say, hey, guess what? We're cutting you short. And yeah, that's perfectly fine with me. I'm going to try to share my screen.
Okay.
But I don't usually do that. So if I have any issues, then I'll have you do it. But I made a couple notes to myself. That's why I wanted to share.
Perfect. Yeah, I made you a co-host, so you should be good to go.
Sweet. Okay, now let me just figure this out. Okay, hold on a second. Let's see. Hold on. Can you guys see my screen? I don't even see anything anymore.
Yeah, we can see it.
Okay.
Can you see it?
I can now.
Okay, good. We can too.
Yeah. Okay. I just wanted to make sure. All right. So, so today I'm going to talk about hepatitis B and hepatitis C co-infection. And it's really not a coexisting infection. It's more like a competition. So that's why I've got this little picture down here. And so you've got your Hep B virus and your Hep C virus, and they compete with each other. But we'll talk about that in kind of more professional detail, I guess. My objectives today are to review the transmission modes, discuss the viral interaction and the concept of a dominant virus between the two, describe the clinical features and outcomes, compare the impact of treatment on the coexisting virus, and then understand hepatitis B management with our hepatitis C direct acting antiviral therapies. So both viruses have shared modes of transmission. Both are bloodborne pathogens. Hepatitis C acts more like HIV in terms of transmission, so not just blood transmission, but also mucosal contact. And Hep B virus can be detected in saliva, semen, sweat, tears, really all body fluids except for stool, whereas hepatitis C is primarily blood transmissible. Hep C is much more efficient sexually as far as transmission and vertically as well. Hep B is 5 to 10 times more infectious than hepatitis C and far more stable at room temperature. So even if you had a dry blood spill or blood spot, it's still highly contagious up to 7 days outside of the body. Hepatitis C, on the other hand, it can survive on average about 16 hours. Some studies say up to 3 weeks on dry blood spots, and that's at room temperature. But there's lower amounts of viable virus or infectious virus. Some studies say that in a syringe, so that's why we see this transmitted so efficiently with our injection drug use population, is that it can even remain in a syringe up to 5 months or any kind of liquid medium. So at the right temperatures, it can stay there for several months. There's a very low prevalence of both hepatitis B and C in the United States, although kind of the caveat to that is that West Virginia varies between number 1 and number 2 in terms of the highest number of acute cases. Most hepatitis B in the United States results from injection drug use or sexual activity or even occupational exposures, whereas hepatitis C is mostly related to injection drug use, and we don't really see sexual transmission except with men who have sex with men, and particularly those that have HIV infection that have male-to-male sexual contact. Now, perinatal transmission with hepatitis C is on average about 6%. It's a little bit higher, up to 10%, if they also have HIV co-infection, whereas hepatitis B, there's really 90% rates of transmission if there's no mitigation strategies utilized. And so this is a vaccine preventable disease. You can treat pregnant women. They administer IVIG at birth to babies. And so there's many strategies to reduce that. But if nothing is done, very, very high vertical transmission rates. The primary mode of transmission in endemic areas of Hep C, like the Western Pacific and Africa, that's typically through either vertical or horizontal transmission, which sucks because, again, vaccine preventable. But unlike adults, so if you're an adult and get exposed to hepatitis B, 95% of the time you don't develop chronic hepatitis B infection, but unfortunately kiddos, especially infants who are exposed to hepatitis B, really develop chronic infection 95% of the time. So adults, 95% of the time they have good immune control. Kiddos, 95% of the time they develop chronic Hep B, and unfortunately the sequelae from that, so complications like liver cancer and liver cirrhosis. Dual infection, it's not uncommon in highly endemic areas, and among those that have high risk of parenteral infection. So estimates of about 1 to 5% co-infection worldwide, but we really don't know the exact number. The reported prevalence really varies widely with different studies, and that's dependent on who you're looking at and where you're looking at, you know, US versus Asia, or IDU versus vertical transmission. So it's really variable. About 5 to 20% of those with chronic Hep B, and again, varies with the study you're looking at, have hepatitis C antibody positivity. So not necessarily chronic Hep C, but have had exposure to hepatitis C. 2 to 10% of those with chronic Hep C have circulating hepatitis B surface antigen. However, occult Hep B infection, and that's either described as having reactive hepatitis C core positivity without good immune control, or that isolated core positivity that we talk about all the time, or that have low levels of positive DNA virus. You know, that's actually can be identified in up to 50% of patients with chronic Hep C. So we see it a lot if we look for it. And that's probably because of the viral replication inhibition between these two viruses that I'll talk about in a couple slides. So bottom line is, you know, if you have one viral hepatitis, always test for the other ones, okay? The viral interactions between hepatitis B and C, just kind of a really brief refresher. Remember that hepatitis B is a DNA virus. And so and Hep C is an RNA virus. So the major difference between these two forms is how the virus attacks the cell. Hep C, it enters the hepatocyte and reproduces itself using reverse transcriptase. Hep B virus also reproduces in a similar fashion, but it's a DNA virus. So it copies its own genome through an RNA intermediate. However, this virus permanently integrates itself into your healthy cell's DNA. So it can stay in the nucleus even though the surface antigen might be undetectable, so it doesn't really ever go away. Because both of these use RNA to make copies of itself, it has high proofreading error, but there are billions of progeny virus produced daily. So that's something that actually is a survival method. There's just, it's quantity over quantity. There's so much virus that, you know, a good amount of it can survive. Patients that have combined hepatitis B and C infection might show a large spectrum of virologic profiles. So if you're checking Hep B DNA and Hep C RNA samples day to day, you're going to see a big fluctuation between these two. We don't really know the specific virological and molecular aspects of dual infection. We kind of partially understand it. What we think is that they're both replicating in the same hepatocytes, and this can lead to reciprocal suppression or viral interference. Thus that competition between those two viruses. Usually Hep C wins, it's the more dominant virus, because Hep C proteins, specifically like the core protein and then the NS5A protein, they can inhibit Hep B activity. And that's, again, why we see that phenomenon of isolated Hep B core positivity, or that serologically silent occult Hep B infection. However, there really can be a huge dynamic fluctuation of Hep B and Hep C viremia. And then spontaneous clearance over time of one or even both viruses, it can occur. Actually, hepatitis, underlying hepatitis B infection, chronic hepatitis B infection, is a protective factor for Hep C spontaneous clearance. So there's a little bit higher rates of Hep C spontaneous clearance if you already have Hep B infection. And then with Hep C superinfection, sometimes you can see that Hep B envelope antigen seroconversion, or even Hep B surface antigen clearance as well. But again, rare, but it can happen. So clinical features of Hep B and Hep C co-infection. So you don't typically see a simultaneous acute presentation. It's rare. It's typically a superinfection. You've already got one and then you get exposed to the other. The acute clinical features are really comparable to monoinfection. So that acute hepatitis picture, it doesn't happen most of the time. It's about 1/3 of the time, but it typically starts as like a serum sickness, and then you get that jaundice and dark urine and all those nasty things, and those symptoms can last for a month or even longer. But most cases, Hep B and Hep C dual infection are diagnosed in the chronic phase. If you do see hepatitis B superinfection, it tends to have a delayed appearance of surface antigen and then shorter duration of that surface antigen. Chronicity rates, again, are comparable to patients with monoinfection of either viruses. So you do have that small increase in likelihood of spontaneous clearance, but not really that significant. Fulminant hepatic failure is really significantly higher in those with superinfection than with monoinfection, but still just occurs in a minority of the cases. Our clinical outcomes. So there's really conflicting data if the degree of liver damage is compounded by co-infection. So you would kind of think that if you have Hep B and Hep C, then common sense would just say your liver disease progression would be more likely to occur potentially at a faster rate. But some studies say there's really not any difference. Some studies say that there can be some histologic changes that shows that that more frequent progression. And then yet more studies say that, there is far more severe necroinflammation and more frequent progression to cirrhosis and hepatic decompensation with co-infection versus monoinfection. In some hepatitis B, I guess bottom line, just in some Hep B or in Hep C co-infected patients, each virus can exert its own pathogenetic role, and that's unpredictable. So it could cause a cumulative effect in terms of liver injury, and that might explain the high degrees of disease severity that's observed in some cases. What about hepatocellular carcinoma? So remember that with hepatitis C or chronic hepatitis C, your HCC risk is pretty low. It's about 5%, and that typically requires you to already have advanced scar tissue set down or cirrhosis. We don't really see hepatocellular carcinoma develop it at any stage. With hepatitis B, a fourth of those that become chronically infected with Hep B in childhood die prematurely of cirrhosis and of liver cancer, and mostly that's silent, so they're asymptomatic until they're not anymore. And that's due to that X protein. If you remember Dr. Gilfus's talk, he talked about the oncogene, the Hep B oncogene, that really charges Hep B and it promotes oncogenesis. And so that's why we can see liver disease progress at a much faster, unpredictable rate, and then hepatocellular carcinoma develop even in the absence of cirrhosis. So with Hep B, HCC surveillance is really stratified based on certain characteristics. How active the hepatitis is, whether that be through their ALT inflammation or elevation, high Hep B viremia, if they have a family history of hepatocellular carcinoma, if they're of Asian or African descent, if they're more advanced in age, because that incidence of HCC in those groups exceeds 0.2%. So with co-infection, there really is a clear synergism between Hep B and Hep C carcinogenesis and develop of hepatocellular carcinoma. In a longitudinal study, the incidence of HCC per 100 person years, it was 6.4 in co-infected patients, as opposed to 2 in Hep B monoinfected and less than 4 in Hep C monoinfected. So the cumulative risk of developing HCC at 10 years, 45% in co-infection, as opposed to 16% in Hep B adult monoinfected patients and 28% in Hep C monoinfected patients. So the real strategy is viral eradication of Hep B Hep C and or Hep B viral control. That's the most efficient strategy we have to kind of mitigate the risk of HCC development. But you're still going to be at a higher risk if you have liver cirrhosis, because once that's occurred, even with eradication of the viral hepatitis or Hep C virus, your cirrhosis is kind of considered your neoplastic state, and so you're still at that higher risk. Therefore, we can kind of assume that, you know, a co-infected patient that does have known or suspected advanced fibrosis or cirrhosis should really be followed regularly. And that means every 3 to 6 months with imaging. So ultrasound imaging labs, even after Hep C has been treated and even despite Hep B virologic control. So what are our treatment considerations? You know, our goal is really to, with Hep C therapy, it's cure. So a sustained virologic response. And that's through the use of our direct acting antivirals, which really disrupt the HCV replication cycle and eradicate the virus. The goal of Hep B therapy is much different. It's really virologic control in the setting of very clear-cut treatment indications, and there's a well-defined treatment algorithm. So basically treat everyone for Hep C, except for very rare instances. With Hep B, it's going to be the opposite, really only treating in specific instances, because if you start Hep B agents and someone decides to stop them, you have a really high risk for flare. So you don't just go and treat everybody's hepatitis B. So what's the impact of treatment on the coexisting virus? So if you've got somebody that you're treating for hepatitis B, what's the risk of Hep C reactivation? If your Hep B replication is inhibited by antiviral therapy, a reactivation of Hep C infection is possible, but it's rarely observed since Hep C is typically the dominant virus. And even if you do see an increase in Hep C viremia, it's really not significant. So it's typically without any kind of clinical events, and you might notice a little bump in their liver enzymes, but it's typically not clinically significant. Certainly monitor for signs and symptoms of clinical hepatitis, because even though it's rare, it could happen, but there's really not any specific guidance on how you should monitor hepatitis C viremia for flare, or what you would do about it, other than what you would already be doing anyway if they were mono-infected. Hepatitis B reactivation during and after Hep C therapy with our direct acting antivirals. This is the thing that we harp on, you guys, like every time that we do a session, is make sure you're checking your Hep B serology, make sure that you know who's at risk for a flare. This is completely different. So Hep B reactivation with Hep C treatment can kill someone. And so this is really serious. If there's only one thing that you take away from this talk, or one thing you take away from any of our echo sessions, it's knowing what's going to kill your patients, and that's Hep B reactivation with Hep C treatment. After the initial DAA agents were approved, the FDA came out with a drug safety warning, and that was back in 2016, in which they identified, this is post-marketing, 24 cases of confirmed reactivation in patients that were receiving direct acting medications for HCV treatment. So when they issued the safety warning, there were 24 cases. They actually published data on 29 cases. The severity of that hepatic damage or reactivation, it could range from just the DNA viremia increased to hepatitis, to fulminant hepatic failure requiring liver transplantation, and then there were also 2 deaths reported. The clinical events were more common in patients that had either a detectable Hep B surface antigen. They were much lower in those that had that isolated core antibody positivity. But in those 29 case reports, a lot of that serologic data was missing. The other things that they reported was this Hep B flare could happen regardless of what DAA agent was used. And it typically happened 4 to 8 weeks after initiation of the DAAs. So why does this happen? And we can presume that it's, you know, like I said, the specifics aren't well understood, but we can assume that the reciprocal inhibition of circulating Hep B that was previously imposed by your Hep C dominance, it's removed once that Hep C viremia is getting cleared. So now Hep B is becoming the dominant virus, and that's what's resulting in the activation. This ended up it's now a black box warning on all DAA labels, basically saying that if you have current or even prior exposure to hepatitis B, there's that risk for flare, and that all healthcare professionals should screen for Hep B, and then monitor for flares or treat Hep B. After that initial kind of statement was issued, there's also been meta-analysis and several studies since then that have gone back and looked. Again, Hep B reactivation and clinically significant reactivation is most frequent in patients with a Hep B surface antigen that's positive. It's pretty rare in individuals that have isolated core positivity, but it still happens. So on average, about 24% will reactivate if their Hep B is surface antigens detectable prior to starting Hep C treatment, but less than 2% if they have isolated core. And then the risk of Hep B related hepatitis was 9% with chronic Hep B infection. However, with isolated core, there weren't, and undetectable Hep B DNA at baseline, there weren't any clinically significant flares. So just be aware that the risk of virological Hep B, reactivation in clinical Hep B is was really not significant in patients that had cirrhosis versus patients that didn't. So your cirrhotic status doesn't matter. Your Hep B status does. So to really stratify your risk of Hep B reactivation during and after DAA therapy, make sure you're obtaining your baseline Hep B surface antigen, your anti-hepatitis B core antibody to antigen, and then your hepatitis B surface antibody. All three of those should be checked before you start Hep C treatments. What do you do when you have a positive test? Because we don't talk about that ever, because we don't see that hardly, but it happens. So the recommendations really vary pretty widely based on which guidance you're referencing. The European Association for the Study of Liver Diseases 2017 guidance just says if your Hep B surface antigen's positive, prophylactically treat hepatitis B before starting your Hep C agents until 12 weeks after treatment completion. If you're looking at the American Association for the Study of Liver Diseases, the 2018 guidance says you don't necessarily treat if you have hepatitis B surface antigen positivity. You really would do it based on the Hep B treatment guidelines. So monitor the ALT and then Hep B DNA every 4 to 8 weeks while on treatment, and then 3 months after they finish Hep C treatment, continue to be monitoring those, and then you would only treat if they meet criteria based on the ASLD guidance, chronic Hep B guidance. And then, I'm getting click happy. And then the Asian, this is why I have to have my notes because I forget what all these abbreviations are for. The Asian Pacific Association for the Study of the Liver, their 2019 guidance says you only prophylactically treat Hep B patients that have either underlying cirrhosis or advanced liver fibrosis or have had prior hepatocellular carcinoma. And you would prophylactically treat their Hep B until at least 24 weeks after DAA completion. If they don't meet those criteria, you could treat them prophylactically anyway, or you could just monitor. So there's really wide variance as to what you do depending on what guidance you look at. So I'm going to tell you Kaylee's guidance because this is this is how I would approach it. My opinion. If you're checking your Hep B serology and you have a positive Hep B surface antigen, check your baseline DNA, check your pre-core, so your Hep B E antigens and Hep B antibodies. Go ahead and start hepatitis B treatment, usually preemptively, like 2 to 4 weeks before you would start your Hep C agents. To minimize reactivation, because again, those surface antigen positive patients are the ones that we see die. And then continue your nucleoside or nucleotide inhibitor for at least 3 months following completion of Hep C treatment. So at SVR 12, kind of consider discontinuation of the Hep B agent. unless they, for some reason, would meet Hep B treatment criteria that would suggest you need to continue it. Once you stop Hep B treatment, make sure you're monitoring for flare, because that's when you see flares, is when you're stopping treatment, not typically while you're on it. And then I put a little footnote, refer to Dr. Gilfus's didactic, because he did a really good 2-part didactic on Hep B that included treatment options. You can refer back to that for kind of more specifics on hepatitis B. If you have a positive Hep B surface antibody, regardless of whether or not your Hep B core is positive or negative, this is where you're in your safe zone. You can proceed with your direct acting treatment. You don't have to do any additional monitoring. These patients, whether or not they have immunity through vaccination or natural immunity with good protective antibody, you don't see that flare, Hep B flare with Hep C treatment. Now the core, the isolated core that we always get all, stuffy about, I would check the Hep B DNA as well as your pre-core. If baseline DNA is not detected, so they have a positive core but no baseline DNA, you could probably just monitor their liver enzymes every 4 weeks, monitor and counsel the patient to let you know if they develop any signs of clinical hepatitis. If their AST or ALT values increase 2-fold, then repeat your Hep B surface antigen and a quantitative DNA level. And then you can start treatment if either of those are elevated or based on the chronic Hep B guidance. If your baseline DNA is already detected, I would anticipate going ahead and starting prophylactic treatment, especially if they already have baseline advanced fibrosis or if they meet your Hep B treatment criteria. And just kind of quick Hep B treatment criteria, usually it's if your ALT is more than 2 times the upper limit of normal. That's what I'm trying to say. And then the DNA level threshold of when you would treat is really based on the pre-core mutants. So that's kind of guidance that you would reference if needed. There's my references and I'm done. And I probably confused everybody, but that's okay because it's confusing. So then you can ask me questions and I can try to speak better.
No, I thought that was really good. Thank you so much. Another great didactic by you, Kaylee. It's very informative, especially trying to ride home the HCV reaction when it's noticed. So I think that's an excellent point for everyone to hear. Does anybody have any questions or comments for Kaylee?
That was great.
Yes, I agree with Jim Boyd. I was going to say that was wonderful. And I think we've had some newcomers, especially from Tug River, onto the echo calls here recently. And I think it is a lot, but I would reassure those that are new, it gets easier once you've seen it and heard it several hundred times. And, I've actually have a couple patients that have co-occurring Hep B that I've treated at this point. And so it's not impossible. It's not something you're going to do probably in your first year of treating hepatitis C patients, but it's something that at some point may get into your repertoire. So it's not as complicated as you think it might be.
Great, thank you so much. Does anybody else have any comments or questions before we move on to the case? Well, if you think of any, please do not hesitate to reach out to me and I can reach out to Kaylee. Happy to do that for you. Thank you again, Kaylee. That was a wonderful presentation. And I will go ahead and share my screen. You ready, Dr. Bailey?
I am ready whenever you are.
Perfect. Can you see that okay?
Yep, I see that just fine.
Perfect. All right.
All right, so this is a really straightforward patient. He is a 33-year-old male who was recently released from incarceration. He had been in prison or jail for 4 years and 7 months. And he got out in July of 2020. I can imagine that was probably a pretty difficult time to be coming back into the world. But after he was released, he, was kind of doing it on his own for a while. He'd previously been an IV drug user, but he relapsed and used methamphetamine one time, I want to say in about April And he kind of said that he did that because he got around some people that he knew he probably shouldn't be around. And so that was a pretty big eye-opener for him. He had been sober the whole time that he was in prison. He had gotten some education while he was in prison. He was looking forward to coming out and kind of having a fresh start. And so when that happened, he realized that he needed to do something to kind of keep himself sober and on a straight path. So he got into the Suboxone program at Southern Highlands, and he has been doing well in that. He was living in a sober living house for a little while. I think we recently got news that he had moved out on his own, but we do seem to have appropriate contact information for him. So hopefully that will continue to work out pretty good. His other medical issues, some anxiety, depression, asthma. He does have a heart murmur. He's going to go see a cardiologist for that. Medications that he's on, Wellbutrin, vitamin D, hydroxyzine, Remeron, Suboxone, Effexor, and some ketoconazole shampoo. It says there that he's not immune to hepatitis A. He is actually immune to hepatitis A. It came up positive total antibodies, so he doesn't need any vaccines. His BMI is there. You won't notice his BMI is there. He's a relatively normal weight fellow. And then we'll get into his lab work a little bit. White count looks okay. No anemia. Platelets are on the low side of normal, but they're fine. Glucose, protein, everything pretty much normal. His AST and ALT are a little high. His ALT was 113, AST was 77. His outfloss was normal, bilirubin normal. His APRI was pretty much fine, and his MELD score was fine. I think the only real abnormality that we saw on his basic labs were just the pretty significantly high liver enzymes, about 3 times normal. His ferritin was okay. His iron was okay. Vitamin D was a little low, so we're replacing that. AFP was fine. HIV was negative. Genotype 1A, viral load was pretty good. And his fibrosis marker was still at 0. So the only really discrepancy I see with his labs are the difference between the ALT and the AST and the fibrosis marker. I think that, I'm not totally sure what that represents, and our plan there is just to go ahead and treat him for Hep C, because he doesn't have any contraindications, and then follow the AST and ALT after getting him treated and see if he's maybe just got some inflammation that'll go away once we get that treated. If it doesn't improve, we'll get a more thorough workup. We do plan to get an ultrasound on him at some point, and I just don't think that's been done yet. So our plan with this guy is to move forward with Maverick. He does have West Virginia Medicaid, so we will need to prove that he has had hepatitis C for at least 6 months. We do thankfully have a old viral load from when he was in prison, and we should be able to prove that now. Also, he did have that relapse, but he's pretty close to 6 months away from that relapse, and he's very stable, has been very consistent with keeping his appointments. I guess an interesting thing about this guy is that we have, I've done all of his evaluation via telemedicine. So recently, I'm not sure if Robin has mentioned this, but we recently opened an office in the Princeton office of Southern Highlands, and we're providing the physicals for the patients who are going through their program. And so that's what Robin is, her primary role is to take care of the medical needs of the patient over there. And so when we first started that, whenever those patients were coming in for physicals and we were detecting hepatitis C, they were being referred to me for telemedicine appointments. My office, of course, is not over in Mercer County. So this was one of the first guys that we were working on, and we're hopefully about to get him treated. We have had a provider at Tug River do a physical exam and have inpatient visits with him. I just haven't personally. So I'm pretty excited to get him treated. I think he'll be a good guy to move forward with. And I'm excited that Robin is here and she's starting to get some of the other patients over there treated. So that's about it. We're planning to move forward with MAVREAD. I don't know if you guys have any questions or suggestions otherwise.
Hey, this is John. You noticed a disparity. Actually, can you guys hear me? Any feedback from anyone? Can they?
Yes.
Yep, I hear you.
Okay, great. Hey, you noticed a disparity between the transaminases and the fibrosis score. Is that correct?
Yes. Mm-hmm.
Well, one of the things you might find is that the transaminases more closely correlate with the activity score on the fibro test. I was not sure if you had that one in front of you to see where it was on
Yeah, I can find it. See if it'll come up for me. It looks like, yeah, his activity score was an A3, so
okay,
severe
so,
activity.
Yeah, so it makes sense. So remember that the transaminases can even kind of go in an opposite direction than the fibrosis score. So those with not a lot of live hepatocytes don't have as much AST or ALT to release. So yeah, cirrhotic patients can have really fairly normal liver enzymes. Whereas again, think of the activity score as a impetus to jump all over it like you're doing. So I agree 100% with your management and drug choice and everything. So good job.
Sounds good. Thanks.
Thank you so much for that, Dr. Gilfus. Does anybody else have any comments or questions?
Just great didactic, Kaylee.
Great case presentations. Thank you guys both
Yes.
very much. And
Yes.
awesome, you guys are doing telemedicine. I love it. I'm so happy. That's such a service, such a great service to our state. And this is one of those conditions you can treat Hep C safely with telemedicine, and it's increasing access to care. And I really commend you guys for opening that door. So thank you guys very, very much.
Thank you
Great.
for saying so.
Thank you so much. Well, if there aren't any further questions, like I said, always reach out. We're happy to help. Our next session will be July 22nd with Dr. Gilfus presenting on initial evaluations. So thank you everyone for coming today. Thank you again to our presenters, and you guys have a beautiful day.
Thanks, everyone.
Bye, guys. You too.